given plenty of eating disorder lectures before, but it's been a while, so sorry if I sound like I don't know what I'm talking about. I promise I do. I'm from California originally. I spent a few years in North Carolina, ended up in Texas for med school, stayed there for residency, and then decided to do a fellowship in adolescent medicine. And the reason why I liked adolescent medicine is because they did things that other pediatricians were afraid to do. So, for example, we deal with eating disorders, we deal with anxiety, we deal with depression, and we deal with birth control, we deal with STDs, we deal with sexuality and gender. And I think a lot of times pediatricians are pretty comfortable with the little kids, but not as comfortable with the teenagers. And at first I thought I was the same way, but once I spent some time with them and realized that if you just talk to them like you talk to a colleague or an adult, like a peer, almost, you can gain their respect, and they will actually be pretty darn honest with you. So a big issue at adolescence is eating disorders. And there are origins of eating disorders much earlier, but we tend to see people between the ages of 10 and 25. Now, every once in a while we get a referral for a kid that's like 8 or 9, and we try and figure out if they're appropriate for us or if they need help somewhere else. But in general, eating disorders come to us. There's only 3 places in the state that really deal with eating disorders, and we're the only one that accepts sooner care, and we're the only one that will admit kids under 14, and we're also the only one that will admit males. So despite the fact that people think of males as being a pretty small percentage of this population, we find that it's really growing, and I think the identification is really growing. So hopefully we're filling a niche that isn't being filled, and right down the road. So, and thank you for that lovely map. It was perfect instructions of how to get to the parking in the building, so I appreciate it. Okay, so I don't have anything. I'm not going to discuss any unapproved drugs or anything like that. We don't really use meds other than SSRIs, and I don't really have any relevant financial relationships. So, goals. At the end of this talk, the learner should be able to recognize epidemiologic patterns of eating disorders and identify the new diagnostic criteria from the DSM-5, describe common presenting medical signs of eating disorders, and identify criteria for emergency hospitalization for patients with eating disorders. I think we all know that media, toys, etc. has a really skewed image of what is a normal body. You know, this is the original Barbie that they all put out, who literally would topple over if she was a real person. This is the newer, more updated Barbie that's a little bit more accurate. Still pretty unrealistic, but pretty accurate overall. So what about eating disorders on social media? Okay, how many of you are on Pinterest? Yeah. How many of you are on Facebook? Instagram? Yeah, okay. So it's all over the place, right? It's like constant. So there are a whole lot of pro-ANA websites. Pro-ANA is pro-anorexia nervosa, okay? I don't know about you, but I pinned like a few weight loss recipes or workouts, and then all of a sudden I started getting all these things on how to skip meals, how to eat less, how to lose weight, how to target your tummy, how to get better biceps, get a better butt, and it was just constant. And so I had to hide all of those because I was like, yeah, I work with kids with eating disorders. I'm not going to follow your website, you crazy people. A lot of our kids look this stuff up and they are experts. Like they'll come in and they're like, oh yeah, well I read about crumbing. And I'm going, what? And it's basically where they crumb their food so it looks like they ate all their food, but there's a whole bunch of crumbs left on their plate. Now, we have nurses, nursing techs that watch our kids eat, and they're pretty aware of this. We also have a clear table so that we can see if they try and hide food under the table. We'll talk about where places people hide food later. So what's the epidemiology? So, lifetime prevalence of eating disorders. Anorexia nervosa is about 1% of women, 0.9%, and 0.3% of men. Bulimia nervosa is a little bit higher. It's 0.9 to 1.5% in women and 0.1 to 0.5% in men. Then there's kind of these other categories, which we'll get more into later. But eating disorder not otherwise specified, I can speak today, which is now called other specified feeding or eating disorders, is about 2.4%. So it's kind of a catch-all, right? And so it's people that don't necessarily fit the criteria for anorexia nervosa. They don't necessarily fit the criteria for bulimia nervosa, but their eating habits still aren't normal, right? And I think a lot of us have seen either in ourselves or our friends some disordered relationships with food. It's pretty common. It's encouraged in society today, unfortunately. And then binge eating disorder is pretty common as well, 2.3 to 3.5% of women and 0.8 to 2.1% of men. Now I will describe binge eating disorder later, but we try to discourage medical people from reading it because when you read it, you'll be like, oh, I've done that. Oh, I've done that. Oh, I've done that. Because on a rotation, you're like, okay, I don't have time to sleep. I don't have time to eat. I'm not hungry right now, but I'm not going to get to eat for 6 more hours, so I'm going to eat as much as I can right now. And it's obviously a binge, but it's really a function of staying alive when you're on a rotation. So, you know, try not to give yourself too hard a time, okay? So what about mortality? So people think of anorexia nervosa, they're like, oh, they're just thin, right? Well, that's not really accurate. The mortality rate of anorexia nervosa per year is 0.51%, which is the highest of any mental illness, okay? So in the DSM-5, higher than depression, higher than schizophrenia, higher than bipolar disorder, all of that, anorexia nervosa has the highest mortality rate. So it's really serious. And of that, 20% of those deaths are from suicide, which means that 80% are medical complications. 80%. So it's pretty bad. Bulimia nervosa is 0.17% annually for mortality, and 23% are from suicide. And then the eating disorder not otherwise specified is 0.33% per year. Binge eating disorder, there's not a lot of data on the annual death rate. There was a small study that showed that 2 out of 68 patients had died. So be aware of this. And like overall lifetime mortality of anorexia nervosa is about 10% per person. So it's 0.51% per year, but lifetime-wise, it's 10%. What about eating disorders in men, right? So historically, we estimated it was about 10% of patients, right? However, newer studies are showing that it's closer to 25% for anorexia and bulimia, and 36% of binge eating disorder patients. I think a lot of times it gets classified as, oh, he's just super healthy, he's really health conscious, he's a bodybuilder, things like that. But I think we've all known men who, whether it was they were gearing up for wrestling or they were, you know, a runner or something where you saw some behaviors that didn't seem quite normal also, right? So it does exist in men, and we had a week where we had all male patients. It was all male patients admitted to our service. And the poor med student was like, is this normal? And it was like, yeah, here it is, because we see males and nobody else does. But it's higher than you think, and I think it goes unrecognized. And I think there's a lot more stigma attached to it for men, right? So being aware that there might be something going on, and that if somebody is underweight or has growth failure or other issues, there might be something that we need to address. So what age do eating disorders start? So about 10%, this lovely, okay, let's see if I can do it. This one is the 10%. 10% of people with eating disorders start at age 10 and younger. Then 14% are after age 20. 43% are ages 16 to 20, and about 33% are ages 11 to 15. Right, so it's a lot of the younger kids. A lot of the younger kids. Now they may not present till later, but it's starting at that age. And sometimes when you talk to these people and you ask, well, when did it really start? And they're like, well, I noticed the weight loss a few months ago, but she's always been worried about her weight. She's always been stressed about that ever since she was in 4th or 5th grade, and it's always been an issue. She was picked on at one point, and then it kind of snowballed from there. Okay, so, but it's not just young women, right? That is the majority of what we see. Obviously, we're adolescent medicine, so we don't see anybody over 25, so that's all of what we see. But it happens in older women too. So in 2012, there was a study in the International Journal of Eating Disorders, which is one of our big journals, obviously, and 1,800 women aged 50 and older surveyed about eating disorder symptoms were surveyed. 3.5% of them reported binge eating, 8% reported purging, 70% reported trying to lose weight. I think that number probably makes sense to a lot of us. And 62% reported that their weight or shape negatively impacted their life. So this is people over 50, possibly older than some of your parents. So, you know, it's an issue for everyone, and it's something that's important to pay attention to, whether or not you're seeing adults or adolescents or pediatrics. I have a colleague in family medicine, and she recognized bulimia in a 64-year-old recently that was hospitalized. They couldn't figure out why she was vomiting. Turns out she was making herself vomit. So, but she recognized it because she had worked with us quite a bit, and nobody else believed her until she really talked to the woman and showed that it really was an eating disorder. So what about recovery? Because this is all really depressing, right? So what about recovery? So there's this lovely person in Europe named Steinhausen who has done a lot of research on eating disorders, especially about recovery and long-term prognosis and that sort of thing. And what he found is that 45% of bulimia nervosa and 46% of anorexia nervosa will have complete recovery. Complete recovery. Out of disease, healthy, doing well. 27% of bulimics and 33% of anorexics will have partial recovery. And then 23% of bulimics and 20% of anorexics will have chronic disease. So it's often relapsing, remitting, that sort of thing, or just chronically underweight. I saw a patient a few weeks ago, and she came in and she was 20, and she said, I've had this since I was 12. I never wanted to seek treatment before, but now I'm really tired of eating chicken and broccoli. And so I would really like for my life to be more than about just chicken and broccoli. And really them wanting to get better is the most important thing, because especially with the older kids or young adults, I can't go to your house and make you eat the right stuff. Like I can't be like, eat more, eat. I can. I mean, I say that all the time, but it's not going to help if they don't want to. So for adolescent patients, 69 to 85% of the patients recovered in 10 to 16 years. So it's still a long road, right? It's still a long road. And the average duration of illness was 57 to 79 months, so several years. But they can recover. So we know these patients really well because they come in to see us at first they see us every few weeks or every week. And then eventually, further down the road, we space it out to every few months, but we see them for years because we really want to get them to recovery and see them through and help them graduate high school and college and go on to live their dreams, which is great. And a lot of them actually end up in areas around eating disorders because it's impacted their lives so much. So what is the definition, what are the definitions of anorexia and bulimia and all that stuff, right? Okay, it's changed a little bit. So realize that it's both a mental and a physical illness with abnormal behaviors, beliefs around food, weight, and exercise that lead to the detriment of physical and emotional health. So it's two pieces, right? So a lot of people want to deal with just the physical part, but you can't do that without addressing the mental health aspects of it. So DSM-4 was the previous diagnostic statistical manual. Yeah, but now we have DSM-5, which is a little bit updated. Beautiful, new and improved. Unfortunately, I think a lot of people are still using old references, and so they still think that there's certain criteria. And what they really did in DSM-5 is they kind of broadened the criteria so that more people actually fell under the umbrella of treatment. Okay, so more people could get treatment. So, anorexia nervosa. Okay, the body weight criteria. In the past, they said that anybody who was refusing to maintain body weight more than 85% of what's expected for height, weight, age counted as was part of the diagnostic criteria. Now it's changed to restriction of energy intake relative to requirements leading to markedly low body weight. So it's not a specific number anymore, because everybody has sort of a different set point, and what's healthy for them is different. Fear of weight gain. So in DSM-4, although underweight, intense fear of gaining weight or becoming fat. And then in DSM-5, it includes that, but also persistent behavior to avoid gaining weight, although at a markedly low weight, right? So so you ask a kid, well, what if I told you had to gain weight? And they're like, oh, I'd be fine with it. And you're like, great, I need you to add these things to your diet, and I'll see you back next week. And they've lost another 2 pounds. despite the fact that they've been given instructions, they've said, oh, I want to gain weight, I want to improve, they are still afraid to improve, right? And so sometimes it's not necessarily what they say, but it's their actions that really cue us in to what's going on. Body image. So disturbance in the way one's body weight or shape is experienced. Denial of seriousness of low body weight, undue influence of body weight or shape on self-evaluation. So what happens if you tell somebody with anorexia, okay, draw an outline of what you think your body looks like on the ground, and then you have them actually lay down and you trace it out, they will have drawn somebody much bigger than they actually are. They see themselves as overweight despite the fact that they're literally dying of malnutrition. So it's that persistence of thinking of themselves incorrectly. And then denying the seriousness of low body weight. We'll get into sort of the complications of this later, as we already talked about mortality, right? So obviously it has some pretty serious complications, but the denying of the seriousness of it, it's not really a problem, this isn't an issue. And then their view of themselves really is related to that weight and shape and thinness, rather than all the other things that make up a person, right? In the past, absence of 3 consecutive menstrual cycles was included. However, what large group of people does that ignore?
Males.
Oh, athletes who aren't getting their period actually also fall into this, but that's a whole other lecture. Men, right? It ignores men. They don't have periods. They're not going to lose their period. And here I have seen a lot of girls maintain their periods even though they're 60-something% of the weight they should be. I don't know how it's possible, but these girls are fertile when they really, really should not be. So in theory, this is your best vital sign. In reality, I've kind of thrown it out the window as far as vital signs for my kids go, because some of them are like chugging along at 69% of mean estimated body weight and they have regular periods. It defies logic, but that's okay. Okay. The other thing to realize is that anorexia, there's 2 subtypes of anorexia. So one is restrictive, which is what we typically think of when we think of anorexia, right? So they restrict their calories, probably hyperexercise, all that stuff. The second subtype is actually binge-purge subtype. And the difference between it and bulimia is that the underweight, the fear of gaining weight, all of that, okay? The binge-purge subtype, anorexia nervosa trumps bulimia nervosa. Okay, so if you have somebody that's vomiting, but they're also underweight, et cetera, anorexia nervosa. They don't have bulimia nervosa. Anorexia nervosa trumps them. Okay? All right. So bulimia. Okay. First criteria is that there's a binge. The second criteria is that there's a compensatory behavior. Okay? So binge eating is eating an amount of food in a discrete period of time, about 2 hours, that is definitely larger than most people would eat. This does not include Thanksgiving. Or, which my dietitian refers to as National Binge Day, or a sense of lack of control. So you'll talk to these kids and you'll say, do you ever lose control when you're eating? And they're like, all the time. Like they know they should stop, they know they're full, they know it's uncomfortable, but they literally can't stop themselves. I mean, you know, and I'm sure all of us have had 1 or 2 of those episodes, but it's not multiple times a week and a month. And then the compensatory behavior is recurrent inappropriate compensatory behavior in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, enemas, or other medications, or fasting or excessive exercise, right? So they have this binge, they feel really bad about it, and so they compensate for it by not eating, or exercising a lot, or using laxatives, or using diuretics, or various other things to kind of make it go away. Doesn't actually work that well, which is why most bulimics are usually not in the underweight category. If they are, then they fall into the anorexia nervosa binge purge subtype, right? And then there's a frequency component. So these have to occur twice weekly for the previous 3 months in the DSM-4. But the DSM-5 now says once weekly for 3 months. Okay? So meaning that it encompasses more people, right? So instead of making sure it's twice a week, it's once a week. And then the self-evaluation and the relationship to anorexia nervosa. unduly influenced by body shape and weight, but it doesn't occur exclusively during episodes of AN, right? Because anorexia nervosa trumps it. So the undue influence by body shape or weight. So for example, not necessarily seeing themselves as fat when they're not, but maybe like, nothing looks good on me. I mean, we've all had these days, right? Where you look in your closet and you're like, I can't wear any of this. Where they'll spend hours like trying to figure out what outfit's going to conceal their butt or their tummy or something like that. Something that bothers them about their body, and it can be excessive. Hence why it's in the diagnostic statistical manual. Now there's this new category. So what do you do about the people that are super underweight, and know they're underweight, but just are unable to really gain weight, right? So what about those kids that don't really fit in the body image disturbance category? There's this category called avoidant restrictive food intake disorder. In the past, we only really saw this in little kids, but I think now we're starting to realize it more in adolescents. We actually see a whole lot of this in our clinic. And what it is eating or feeding disturbance as manifested by persistent failure to meet appropriate nutritional and or energy needs, leading to one or more of the following. So they have weight loss or failure to achieve expected weight gain or faltering growth in children, so failure to thrive, kind of. Significant nutritional deficiencies, so for example, scurvy, which I have seen kids with that before. Dependence on enteral feeding or oral nutritional supplements, right? So they're basically like, they won't eat, but they'll take Boost. And so their parents are feeding them shakes, these like nutritional shakes, so that they can function. But that's what's keeping them at their weight, not the fact that they're eating like healthy 3 balanced meals a day, right? Or marked interference with psychosocial functioning. So they go out to a restaurant, but they won't eat the chicken nuggets at that restaurant. And so parents have to take them to Chick-fil-A, because they'll only eat the Chick-fil-A chicken nuggets. I had one kid that would only eat round chicken nuggets. So they would literally only eat round chicken nuggets from McDonald's. So their parents would have to go there, but then they would get the fries from Chick-fil-A. So it would literally take their parents like an hour to feed them just a meal by going to different fast food places. And they would only do Wendy's Frosty. You know, so it's like this, it's very specific, and they only like certain things, and they really often have issues with texture. This is often related to a couple of different things. So one is autism, right? So we've all heard that autistic kids are picky eaters, right? They won't eat certain things, they'll only eat the round chicken nuggets, things like that. They have to cook things in certain pans. That's kind of our fit. And a lot of that is out of texture and sensory issues and the rigidity. The other issue is kids with anxiety. So for example, sometimes kids have a choking episode, or see a choking episode even, and they start to get afraid that when they're going to eat, they're going to choke. So they start limiting their food. So they'll only eat soft foods, and then they'll only do shakes, and then they'll only do thin liquids. And they start limiting their foods further and further and further because they're so afraid of choking or vomiting that they cannot make themselves eat food. We basically have to retrain them how to eat, and also to get them used to that vomiting happens and it's okay. Like it sucks, it's uncomfortable, but it's over, right? These kids are our vomit-fest kids because a lot of times they get to the point where they hit a wall and they can't eat anymore, and in order to support their nutrition, we have to use a tube, and then they vomit the tube, and they vomit the tube again, and again, and again, and again, and it's, you know, frustrating for everybody involved. Really frustrating when they vomit on other people, but usually it's not that bad. But these kids, it's a lot about anxiety, which, you know, anorexia nervosa and bulimia nervosa have an anxiety component as well, but it's not the driving factor like it is with ARFID. So the disturbance in eating is not due to unavailability of food, right? So it's not food scarcity, because we all know that happens. And it's a good thing to screen for when you have a kid that's underweight. For example, we had one patient, he's a long-standing patient of ours, and he wouldn't eat because he wanted his siblings to be able to eat. So he wouldn't eat. So he was severely underweight. And because he was young, he stopped growing. Or to observation of cultural norms, right? We've all heard of Ramadan. That's normal. Like, that's okay, right? So being picky around food because it's part of your religion, not the same thing. anorexia nervosa or bulimia nervosa, there's no evidence, is not related to that, right? This is separate because there is no body image disturbance in ARFID. Now that doesn't mean that some kids don't morph to anorexia nervosa because they've been used to being skinny for so long and they start to develop, that's the body image that they want, but sometimes it starts out that way. And then it has to be separate from another medical condition or mental disorder. Or when it's occurring with one of those other disorders, the disturbance exceeds that which is normally caused by the condition, right? So there's plenty of people that have anxiety. I'm sure some of the people in this room, I know some of my colleagues, I know myself, right? You know, anxiety exists, but it doesn't usually keep us from eating, right? So it's outside the norm for that. All right, so what about binge eating disorder? This is basically bulimia without the purging, right? Same criteria. So binging, frequent overeating at least once a week for 3 months, combined with lack of control and marked feelings of distress. So this is the part that I was like, ooh, as medical professionals, it's kind of rough. So associated with 3 or more of the following. Eating much more rapidly than normal. I'm sure we've all done that, and you really will when you get on your rotations. Eating until feeling uncomfortably full. Eating large amounts of food when not feeling physically hungry. Eating alone because of feeling embarrassed by how much one is eating. Feeling disgusted with oneself, depressed, or very guilty afterwards. So, yeah, I think a lot of us can relate to this. Hopefully not in the one time, the weekly relationship. But it can happen. Oh, and then there's a whole grab bag of other things. Okay, so what about the people that were maybe once overweight and lost so much weight that maybe they're still in the overweight to normal category, but they have all the other signs of anorexia nervosa. Like they have malnutrition, they have bradycardia, they have things like that. That's atypical anorexia nervosa. Atypical because their weight is, they're not underweight. Yeah, and they meet all the other criteria, but they're not underweight. So that's considered part of other specified feeding or eating disorders. Subthreshold bulimia nervosa means that it's either not quite frequent enough or hasn't been going on long enough, right? So maybe it's every other week, or maybe it's only been going on for a month or 2. And so it's not quite meeting criteria for bulimia nervosa, but it's close. Similarly for subthreshold binge eating disorder, not quite the right duration. Purging disorder is when they purge without binging, and they consume a normal amount of food and typically maintain normal weight, but they purge anyway. Night eating syndrome, nocturnal eating episodes or eat a large portion of their daily calorie intake after dinner. So those people that are snacking at 2 in the morning, wake up, snack, eat at 2 in the morning. Apparently Ambien can cause this. And so they get up and they eat a large amount of food, and then so they're getting a large amount of calories in the middle of the night, right? As you might imagine, the body's not really made to do that. We're supposed to technically be fasting, hence breakfast being break the fast, that sort of thing. So a lot of times that can lead to weight gain. And then other feeding or eating conditions not elsewhere classified, which is basically a residual category for everything else. That's like, doesn't seem quite right, but doesn't meet any of the criteria for any of the eating disorders we already discussed. Make sense? Feel free to interrupt me with questions. Sorry guys, I probably should have said that to begin with, not 30 minutes in. Okay, so unless you're my 20-year-old who's like, I have anorexia nervosa and I want to get better, most people don't come in saying they have an eating disorder. In fact, most people really say they don't have an eating disorder. So what should you be looking for? What should you be worried about? The first thing to note is the growth charts, okay? So, growing along, great. Growing along, drop off, right? That's a problem. All of a sudden, they were at nice 50th percentile, and then all of a sudden they dropped off. One thing to note is if this happens early enough before their growth plates is fused, their height might flatten out too. If the weight falls off before the height, it is eating disorder. It is malnutrition. Don't refer to endo. It's malnutrition. If the weight drops off after the height, that can be endo. But if the weight drops off first, it is malnutrition until proven otherwise. Okay? So what about this case? you see this kid's nice and tall, right? Top of their growth curve, doing really well. Weight is in the like, started out at the 50th, has now crossed the 25th, is crossing over to the 10th, and is headed towards the 5th percentile, right? Their weight curve is basically flat. It's not a curve, it's a flat line. That's a bad sign, okay? Luckily they were able to grow, but not everybody is. This is also abnormal, right? Relatively normal height curve, maybe flattened out a little bit early, but the weight's taken off. Yeah?
So could you explain a little bit more what you mean by when it falls off and drops off before and after the height?
Yeah. So, I wish I had a good example of this. So, sometimes what happens, see how this fell off? So, sometimes this falls off here, and if this height, all of a sudden, if this height plateaued before this, like up here, several years before, then I would say it's probably an endocrine disorder. But if all of a sudden you have the height fall off, and okay, this is a bad example because this is where everybody plateaus, but if this all of a sudden plateaus after that height fell off, like a year or so after their weight dropped, that's when you look for it. So you look at, like if you pull out the height curve and you're like, oh man, that kid is not growing. And then you pull out the weight curve and you go, oh, the weight's been poor for a long time, and the weight often precedes the height. So you'll look and they'll, for example, I had a kid, and basically he had not gained weight since he was 9, and at 11 he stopped growing. Okay, so he was 37 kilos at 13, which is not a lot. 37 kilos, like 70 pounds, right? 70 some odd pounds. And so his height, he was shorter than his 11-year-old brother. He's 13 now. He's shorter than his 11-year-old brother. He hadn't entered puberty. And his brother was already starting puberty, even though he was 2 years younger. Because his weight, he literally hadn't gained weight in 4 years. So, yeah. Okay. All right, and so this is more of a concern for like binge eating disorder, bulimia nervosa, night eating syndrome, something like that. Now, not all obese kids have an eating disorder, but it doesn't mean that they have a completely normal relationship with food, right? Does anyone? It's really the question. Okay, so this is more of an example of sort of an atypical anorexia nervosa, okay? See, they're gaining weight, they're at the upper, this is like the 97th percentile, they're at the 97th percentile, they're over the 97th percentile, and all of a sudden then they're down like at 75th. And we would probably all be like, oh, good job, you lost weight, right? Depends on how quickly they lost it, depends on how much they're limiting their food. You really have to worry about what's going on. If this kid comes into me with a heart rate of 45, yeah, I'm admitting them. Even though they're normal weight, it's technically atypical anorexia nervosa. All right, so what are the symptoms that they present with? Well, obviously weight changes, failure to thrive. So we call it failure to thrive in little kids, right? In older kids, it's like growth failure or something like that. So those kids that haven't reached puberty, that haven't, and I'm getting a whole lot of those right now. Those kids that are 13, 14, their younger siblings are further along in puberty than they are. And they're not tall, they're underweight even for their short height. That's a sign of malnutrition, right? Nausea and vomiting. They get, either they're already used to vomiting, or they get so used to not eating food that food makes them nauseated. And they can't eat. And then when they do eat, they vomit it. And some kids have that combination of restricting and purging. And so they are already used to purging, and so their lower esophageal sphincter isn't great at staying closed, so they have a lot of reflux. So, fatigue, which, you know, every teenager I ask in my review of systems has fatigue. I've had one in the last week that said no to fatigue. But fatigue to the extent where it seems abnormal, right? Syncope, fainting. We had one of our patients present to the ER after a syncopal episode, and we were like, okay, time to admit, right? Their cardiac capacity gets so decreased they can't get blood to their brain. So when they stand up, they have huge orthostatic changes, and their blood pressure's crap, so their pulse goes through the roof, their blood pressure drops, and they faint because the blood's not getting to their brain. Their cardiac output's horrible because they have no muscle mass, and the heart is made of muscle, as I'm sure you all know. Dizziness, often with standing, right? Chest pain, decreased appetite intake, makes sense. Behavior changes. Parents will often say, this is not my kid. This is not the kid I recognize. This is not my kid. You're right. It's the eating disorder. It is taking over your child. And it's like a whole different personality. Because when your brain is starved, you don't really think clearly. You don't. So mental slowing is also one. Constipation. So when you don't eat, A, there's not enough food to really make a bowel movement, and B, you get decreased muscle mass, which includes the smooth muscle mass that lines your intestines. So they literally don't have enough muscle for peristalsis to move the food along. Amenorrhea. So I had a patient present, and last year she had lost, she'd been slightly on the heavier side, pretty muscular kid though, and she had lost 30 pounds in a summer. And I mean, that doesn't sound like a whole lot for somebody that's overweight, but it was pretty quickly. And basically her period stopped then. And she got constipated. And she became tired, and all of this other stuff. And so it all kind of stopped right after that. And mom looks at me and goes, "It's all the weight loss, isn't it?" I said, "Yep." She was normal weight, and her heart rate's normal and all of that, but a lot going on. Hair loss. A lot of hair loss, and it takes a while to recover. And then cold intolerance. These kids are cold all the time. You would be too if you had no subcutaneous fat. They are cold all the time. And I'm not talking just in the air conditioning. I'm talking they walk in my office in the dead of summer in a sweatshirt and long pants. And it's 95 degrees out. And they're like, "Yeah, I had the seat heater on in the car." It's 95 degrees outside. I mean, I know mom had the AC on high because she's like maybe perimenopausal and all that stuff, but still, everybody else in the car is wearing shorts, Headaches. I mean, they're malnourished. It's uncomfortable. You have headaches, and it keeps going. So what about on physical exam? What are we looking for? Abnormal body weight. So I don't know about you, but in Houston, I used to run around the track at Rice University, and by run, I mean plod slowly. But whatever. And so I would see these kids running the opposite way, and I was just like, "Where's Dr. Middleman's car?" Dr. Middleman's not my boss here, but I knew her from residency there, and I'd want to be like, "Oh, honey, that's not normal. You really shouldn't be running. I don't think your heart rate's okay." Growth failure. Hypothermia. Legit hypothermia. I have never seen hypothermia in the middle of summer except in my anorexic kids. 96 degrees. Hypo or hypertension, more hypo. Orthostatic blood pressure, heart rate change, so when they go from lying to standing, heart rate goes up, blood pressure goes down. Bradycardia. If a kid is sitting up and talking to you and their EKG reads 38, that is not normal. And I had one parent, and they were like, "Hey, I checked the Guinness Book of World Records, and the lowest resting metabolic heart rate is 27, so his is better, right?" Because he was 21. I was literally listening to him and talking to him, and I'd hear bump, 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 and you could literally count 3 seconds between each heartbeat. This is not okay. It is not normal. If I would be doing chest compressions on you otherwise, like if you were asleep, I would probably start doing chest compressions, right? Because that's bradycardia, right? So if you were at that stage, it's not okay. Not okay. It should be, the heart rate should be at least over 45 when sleeping and over 50 when awake for kids under 18. For over 18, we're a little bit more lenient. I don't know that we should be, but we are. So they need to be over 40 when sleeping, over 45 when awake. But that's still pretty low. And everybody's like, "Well, but they're an athlete." I gotta tell you, I highly doubt Michael Phelps' heart rate is that slow. And he eats 10,000 calories a day. So it's not the athlete thing. And they're always saying, I'm like, an athlete's heart rate can be in the 50s. I'm okay with the 50s. I am not okay with the 30s. Not at all. And when I tell their parents, who of course are like, "But they're athletic," your high school track team kid is not as athletic as you think, right? And we did a cardiology consult on one, and cardiology was like, "Well, I mean like Olympic runners," and so the dad, same dad as the heart rate, was like, "So he's gonna be in the Olympics?" I was like, no, he needs to eat more. So be careful about what you say if you get consulted on these kids. All right, so in the HEENT exam, parotid enlargement from vomiting. Okay, so when you vomit a lot, you produce a lot more saliva. So they will have parotid enlargement that you can actually palpate, and you can feel the enlargement of their glands. It's not soft, it's a little bit more tense, okay? Conjunctival hemorrhages from vomiting, right? So when you have conjunctival hemorrhages happen anytime you have an increased intra-abdominal pressure, right? Temporal wasting, so the really skinny kids will basically have wasting right here on their temporal area. It looks sunken in. Their eyes often look sunken in too. You know, we all have bags under our eyes, especially during allergy season when we haven't got enough sleep, but these bags are impressive. Like, they look like death. Palate ulcerations or trauma, which is this one. You can see there's kind of some ulcers there and there. Dental erosions. It usually happens on the back of the teeth, on the lingual surface of the teeth in the anterior teeth, right? Because that's where the vomitus is splashing. I know, super pleasant to think about an hour before lunch. And then an atrophic thyroid. So everything, so when your metabolism's decreased, your thyroid's gonna be wimpy, right? So when you examine their thyroid, they might have new thyroid, basically. Very small thyroid. Okay, what about the cardiovascular system? Bradycardia. Medial displacement of the heart because their heart muscle mass is so much smaller. I tried to get a really great picture off of Up to Date, but for some reason it wasn't opening. So their heart is basically like skinny, and so their PMI is going to be closer to the middle. Heart failure and volume overload. Okay, so here's the deal. If you see one of these kids in the ER that looks super underweight and is bradycardic and hypotensive, please do not bolus them. You will literally kill them. You will put them into congestive heart failure because they cannot handle the volume load, okay? Their heart doesn't know what to do with it. Their heart is not strong. So they will go, so if you see one of my kids, call me. Or if you see some, before you bolus, call, just call. Always use the gut. They can drink, and they probably have been. They can also get irregular rhythms, right? Because they're bradycardic, and therefore, like, their heart's not quite working right, sinoatrial node's not firing right. They can get junctional rhythms, they can get arrhythmias, and then often their electrolytes are also disturbed. So when you have disturbed electrolytes and some sort of arrhythmia, this is a great way for a patient to drop dead. Sudden cardiac death happens a lot in these kids. Breast atrophy, you can often look at the breasts, and though the breasts appear to be sexual maturity rating 4 or 5, they're shrunken, right? Because it's, well, there is some fat tissue, but it's also mammary glands, and really their body is not ready to have a kid, right? That's kind of why the amenorrhea happens. Your body literally says, oh no, okay, you should not get pregnant right now because you will die. And so it shuts it down. It shuts down the ability to get pregnant. I know that, you know, we don't like to think about it, but evolutionarily speaking, a woman's body is kind of meant for making babies. I mean, that's where it comes from, right? Testicular atrophy can happen as well. A lot of times in these kids, we have to get a testosterone level to see what's going on with their puberty, and it's often super low. What about their skin? Delayed cap refill, right? I mean, if your heart rate's 38, you wouldn't really expect a great cap refill. They're hypotensive, their heart rate's low. They're often not just cool to the touch, but cold to the touch. So a lot of times what we will do is actually like a marker of how well their circulation is, start at the fingertips and feel, and see where it gets warm. Right? Same thing on the legs. Start at the toes, work your way up. If it's wrist or lower, all right. When it's starting to get up to like knees and elbows, we got some problems. Their circulation is not great. They often have really dry skin, so they'll have excoriations or calluses on the back of the hand, which is Russell's sign, which is from purging via emesis, okay? So always look at their hands. Always look at their eyes too. You can tell like pallor and things like that. Acrocyanosis, so they'll be like, yeah, somebody told me I have Raynaud's disease. Nope, that's not Raynaud's. It's not like, oh, 2 fingers are white and 2 are blue. No, it's literally like your hands are blue from the fingers down. Like, that's not Raynaud's, that's acrocyanosis. They're cold as all get out. You feel them, they're cold. And yeah, it doesn't just happen randomly like in the shower and stuff like Raynaud's. Lanugo. So lanugo, if you haven't ever seen it, is this fine, it's like baby hair. It's like fine hair coating their back, their arms, their legs, their face. So in this one, this picture is actually, if you're looking at this, see that fine, thin hair there? I had one patient, he's like, oh yeah, my cousin likes my back because it's so, she calls it furry. I was like, it's lanugo, and it's a sign of increased cortisol from the stress your body is under from the eating disorder. Easy bruising or petechiae. So I know I'm giving a lot of little mini anecdotes. So I had a patient, and she was admitted, and she was severely underweight. It was one of the worst I had seen at that point in my career. And she said, yeah, and I have this weird rash from, I think it's from the shower at school, and she lifts up her shirt, and it's petechiae. And it was from the shower at school, because literally the water pressure was too much for her level of nutrition. Now here's the other thing that you don't want to do with those kids. Please don't put those kids on Lovenox because they're on bed rest, which is what the outside hospital did. It's problematic. She's already bruising and bleeding and has petechiae. That's not going to go well. So yeah, use STDs. Psychomotor retardation and mental slowing. You will ask these kids a question and you can literally watch the cogs turn. They will be so slow and it's painful. And you're like trying to get the history, and at some point you just decide, you know, I don't need the details, we'll figure those out later, because it's, I mean, you'll be like, so do you think of yourself as too thin, too big, or just right? And they're like, I don't know. Okay, so moving on. They often look really flat and constricted. I mean, you need food to be vivacious. Like you need food to have energy and be energetic. Self-injury marks. Anxiety and depression comes a lot from this. It goes hand in hand with this a lot, right? So looking for those lacerations. They're not just on the arms. Other places that people often cut, okay, so which is why you need to get them in a gown for every exam. Thighs, abdomen, okay? Those are the places, so I often ask, where do you cut? And they'll tell me, oh, my left arm. And I have one kid that just cuts right there. and so I'll be like, show me right there. But abdomen's a big one too. And that makes sense though, right? Because there's so much body dissatisfaction, they feel like so empty. And then muscular weakness and atrophy. So with these kids, you don't want to say well appearing, no acute distress, right? You can say muscular wasting, you can say thin or cachectic, if they look cachectic, and point out the fact that they have muscle loss. They do often. So what about labs? All right, so as you probably imagine, since we talked about petechiae, thrombocytopenia is a big one. Anemia, obviously, because in order to not have anemia, you need iron, folate, B12, right? Leukopenia, it's often mild, but if all three cell lines are down, that's pretty far along the disease. I gotta tell you, by the time that they get to the stage where they're having abnormalities on their labs, it's pretty bad, okay? Most kids that come in, even though they're underweight, even though they look awful, their labs are still pretty normal until we start giving them food, which I'll get to in a bit. They can have acute hepatitis and acute pancreatitis, so elevated ASTs and ALTs. Electrolytes, basically all of them can be out of whack, right? So they can have hyponatremia because they're water loading, which means that they're drinking more water to falsely elevate their weight in clinic, which is why we have them pee before we weigh them, and we make them keep peeing until their urine is normal, spec graph-wise. So if that means 7 cups of urine, that means 7 cups of urine, and then we will re-weigh them after that, and it might be 2 pounds difference. Because really, this is 2 pounds. Right? Like this is 32 ounces, so it's 2 pounds. You can chug that before an appointment, sure. So their sodium might be low or high if they're dehydrated. Their chloride is often off, especially if they're vomiting, right? So hypochloremia can definitely happen. Their CO2 is also going to be off if they're vomiting as well. That's going to be super high, right? Potassium is going to be low if they're vomiting. Oh, mag and phos get off too, yeah. So everything gets off, basically. They'll often have a metabolic alkalosis. Their kidneys might look like crap. They might have an elevated BUN or creatinine. So when you look at a person that weighs 80 pounds, their creatinine should be low, right? A normal adult, it's like 0.8, 1. These kids, it's like 0.3, 0.4, okay? And if they come in with an elevated creatinine, they're dehydrated. That's the other thing they do. They won't drink because water adds weight, right? So they'll either drink too much or too little. It's never in between. Hypoglycemia, they might not be symptomatic because they're used to it, but they might be hypoglycemic. Low estrogen and testosterone, as well as low FSH and LH, which means they have hypothalamic amenorrhea, aka everything's shut down starting up here, right? So their hypothalamus, pituitary, gonadal axis is off. Like I said, high amylase and lipase. They can actually have elevated cholesterol, right? So it doesn't make sense, right? People think of elevated cholesterol as a disease of the obese. Well, not when you're breaking down all your body tissues, right? So that includes all your skin cells, that includes whatever fat you have, all of that's getting broken down. Thyroid function. They can have sick thyroid. They can have high reverse T3 and low free T4. So pay attention to their thyroid function as well. And all of this will get better as their nutrition improves. So we can fix all of this as long as they eat. You also want to get an EKG. Okay, so you can have bradycardia, QT prolongation, arrhythmias like we talked about, low voltage, ST and T wave abnormalities, rightward axis, right? Because it's smaller than usual, so you don't have the leftward deviation. Sometimes we get echoes, especially for those kids that are super bradycardic, and it shows, reduced ventricular mass. Shocking, right? They can have a pericardial effusion also, which does resolve with eating as well. And the mitral valve prolapse happens often. We get DEXA scans more than X-rays, but if they have point tenderness, definitely get an X-ray because stress fractures in these kids is super common. I have one girl and she had 4 fractures, 4 different fractures over the course of a year. Osteopenia is a big deal, and they often have it. I've had a few kids where they actually had on the better than normal side of bones, but mostly they're below average. I would not recommend getting an MRI of the brain, but if you do, for the sake of some study you're doing or something, you'll often see small brain volume and loss of gray matter, right? Because what is the brain made of? Fat. Neurons are fat, guys. They're all wrapped in fat. So when you have no fat, no nutrition, you don't have much brain. The other thing to realize is that they often have accompanying anxiety and depression, but SSRIs, which are selective serotonin reuptake inhibitors, really don't work if you don't have any serotonin. Serotonin is just tryptophan, right? 5-hydroxytryptophan. So if you don't have the input to make the serotonin, they're not going to work. So we sometimes don't even think about starting those until they get over 75 to 80% of their mean estimated body weight, because it's not going to do anything. It's not going to work. I mean, sometimes we think about doing it then, starting it early anyway, because maybe by the time that the meds would work on their own anyway, like in 2 months, they'll also be up to weight, but, just something to consider. Okay, so what do you do with a habit eating disorder? What do you need to ask? What questions do you need to ask? I like Kelly's sense of humor. Getting to the history, brought to you by the letters H, P, and I. So there's the SCOFF screening tool. Obviously this is British because it refers to 1 stone, but it's basically screening for an eating disorder. So do you make yourself sick because you feel uncomfortably full? Do you worry you have lost control over how much you eat? Have you recently lost more than 1 stone, which is 14 pounds, in a 3-month period? Do you believe yourself to be fat when others say you are too thin? And would you say that food dominates your life? Ask these kids how often they think about food. They'll tell you it's 95% of the time. It's perseveration on food. More questions. All right, so calorie or food type restrictions. So have you cut out carbs? Have you cut out fat? I had one patient and she'd become vegetarian. Well, she tried to be vegan and we said no. She'd become vegetarian to restrict. And then of course she also wasn't eating fat. And then she told me she didn't want to eat pasta because of the carbs. And I said, so what are you eating? And she goes, protein. I was like, no, you're not, you're vegetarian. Like, she wasn't even eating fish. She was not eating protein. There was no eggs. It's like, you're eating veggies, that's it. Like, it's not a diet. Vegans eat protein. But this kid wasn't going to. Skipping meals, binging, purging, over-exercising. We always do a 24-hour recall, and we are super specific. So they'll be like, cereal. And I'll say, okay, what kind of cereal? Oh, Cheerios. How much Cheerios? That much. Okay. Because a whole bowl of Cheerios is a lot different than a handful of Cheerios, right? What kind of milk did you use with your Cheerios? Oh, you ate it dry? Okay. Like, what? Or you use skim milk, or you use unsweetened almond milk because it's only 40 calories instead of non-fat milk, right? So there's a lot of tricks you can pick up on when you talk to these kids. Did you finish it? What'd you have for lunch? Well, I skipped lunch. Okay. What'd you have for dinner? Oh, a salad. And then she'll be like, yeah, it had some cheese on it. And then mom goes, she literally blew the cheese off. So like they'll literally go and blow the shredded cheese off, right? So making sure that you get those details and really take a good history is important. We always ask if they're using pills or supplements, diuretics, emetics. I haven't had anybody use Ipecac ever. You can't really get it anymore, but you still could when I was in med school, because laxatives. And some of these kids use laxatives because they're constipated, so are they using it 1 time a day for a normal bowel movement, or are they using it 5 times a day? Diet pills, obviously. Weight loss. Quantified. What's your heaviest weight? And what's your heaviest weight? What's your lowest weight? How fast did you lose that weight? Like, how did this happen? Abnormal food behaviors, avoiding eating food in public, cutting up their food super, super small. Vegetarian, vegan, not that it's wrong to be vegetarian, vegan, gluten or dairy free, but sometimes you'll meet these kids and they're like, oh, and I'm gluten free, and I'm vegan, and I'm this, and you're going, what's left? Because they're limiting it so much. Like, we all went through a vegetarian phase at some point, and some people are vegetarian. I went through the vegetarian phase in college until Thanksgiving came, and then I was like, I don't want tofu. But, so everybody, so like there are normal things, but when a 12-year-old goes vegan, that doesn't make sense. Right? Like if a 22-year-old does it, fine, whatever. I mean, but if a 12-year-old goes vegan, how'd you even hear about that? Right? And I literally had a kid, and the other kids would make fun of you if you weren't vegan. He was 12. It's not normal. Excessive gum chewing staves off hunger, as does smoking for some. An obsession about food. They will think about food 24/7. They will make food for other people and not eat it. Okay? So they will be like, oh yeah, I bake all this stuff, but I don't eat any of it. I love to bake. I watch the Food Network all the time. I have 10,000 cooking magazines. I don't eat at all. And they actually did the study, the Minnesota, I think, starvation study, and they kept these guys on 500 calorie a day diets, and they literally became obsessive about food. They would think about food constantly. Body image, asking about goal weight. So we ask, do you feel like you're too thin, too big, just right? And if somebody says they're just right and they're severely underweight, that's still abnormal, right? Goal weight, what would you like to weigh? Because sometimes it starts out, well, I'd like to weigh 100 pounds. Well, I didn't feel good at 100 pounds, so I want to weigh 90. Well, now I want to weigh 75, and it keeps going. So being aware that that goal weight might change over time. If there are surfing websites that are pro-ANA or pro-NIA, and then the symptoms that we already talked about. All right, we already talked about sort of what labs and studies you need, right? So we get a CBC, we get an ESR and a CRP because maybe they have Crohn's, right? Like who knows? They might also have IBD. Maybe what they told you they were eating is right and they're not absorbing it, okay? Maybe they don't have an eating disorder, which actually happened. We got a patient sent to us, signed out as anorexic. Yeah, no, erythema nodosum, anal skin tags, father with Crohn's disease, elevated ESR, yeah, that's Crohn's. So once we got him to CGI, lo and behold, he can eat more, he can gain weight, all of that stuff. CMP, you want the liver function as well. Urinalysis to check for water loading, to check for dehydration, to check for urinary tract infection. Sometimes you'll see ketones, right? Because they're losing muscle and fat. Ketones and various other things in their urine that doesn't look normal. Thyroid function, EKG, especially if they're bradycardic. We also like to get a vitamin D and a zinc. Vitamin D is pretty important, and if they're malnourished, they often don't have it. Zinc is also really helpful to supplement, at least for the first 30 days. After that, it starts to compete with copper. So for the first 30 days of refeeding, it can be helpful. You want to check MAG and PHOS, a pregnancy test, because that can cause issues too. And then if they're having symptoms, a stool guaiac, celiac pain, all that sort of thing, gonadotropins if they're amenorrheic, especially if it's primary amenorrhea, right? They've never reached puberty and they're 13 years and 10 months old and their sister has her period, who's 12. You have to do a workup for delayed puberty at that point. Okay, but what about treatment, right? Because this is a whole bunch of depressing stuff, but do they get better? Yes, we already talked about that. So you really need a multifaceted team, multidisciplinary team. So in our program we have medical doctors, we have a dietitian, and we have therapists, okay? And we all work together, so we have teams around these kids. And often we have one of our therapists is the individual therapist, and the other therapist is the family therapist. Because this stuff didn't develop out of nowhere. It's a coping strategy the person is using, and there's often inappropriate family dynamics that are reinforcing it. So and then also there's stuff that comes up once you start to treat them, right? It opens up a bunch of different issues for people, and so it needs to be dealt with. What about sort of the levels of treatment? Okay, so there's medical inpatient stabilization. That's what we do, and we actually keep them for so long that it's almost like we do part of the psych program too. So we often spend our time calling insurance companies and explaining why we're keeping these kids until they get to 85% of mean estimated body weight. That's out of that guy Steinhausen's research as well. If you keep kids in the hospital to about 85% of mean estimated body weight, they do better long term, fewer relapses, they really do a lot better. So there's medical inpatient stabilizations. There's some places, like the place I trained, that after that we often send them to a psychiatric inpatient admission if we don't think they're going to fly on their own, which is where they stay in a psych hospital once they're already medically stable. Partial hospitalization is basically like a long-term day program. So sometimes they show up at 8 and they're there till 7, and they eat all their meals there. They have therapy, they have physical therapy, they have programmed activities, they go home for their bedtime snack. So they're there all day long, or they might be there till 5 and they go home for dinner and their bedtime snack. An intensive outpatient program might be 3 days a week for several hours. An outpatient program is mostly what is the other half of what we do, where they come in and they're seen once a week or less often if they're doing well. And then residential treatment is really appropriate for people that have maybe been ill for a long time, who have done multiple hospitalizations at various programs, and we really need long-term recovery to really break that eating disorder cycle. So when do we admit them? Okay, so you've heard me talk about mean estimated body weight. Mean estimated body weight, basically, we use the NHANES data, which is like, I don't even remember, but it's like nutritional data from the 70s, okay? The other thing you can do is you can use growth charts and basically figure out what the 50th percentile BMI for their age is, and then calculate back to what that weight should be for their height. Here's the problem though, the growth charts now are actually based on a more obese society, right? Because the obesity curve has kind of trended up, and these are like 2000, 2010 data versus 1970s data, okay? And we're not trying to make our kids overweight because they already have an eating disorder, and that's going to make it worse. So we have some charts that we use for mean estimated body weight. But if a kid is over 18, here's a rough way to do it. If they are a female and they are 5 feet tall, they should weigh about 100 pounds. For every inch over 5 feet, they should weigh another 5 pounds. So somebody that's 5'6", in theory, should weigh about 130 pounds. And we give them like 10% leeway on either side, right? That's a rough estimate. So if you have a kid that comes, and that's not to like say that you should be reevaluating your weight and all that stuff right now, but it's a rough estimate to give yourself an idea of like, okay, what is their mean estimated body weight, okay? For males over 18 that are 5 feet tall, it's 106 pounds, and 6 pounds for every inch over 5 feet, okay? That's just a rough estimate to give you that number. That does not mean that they have to weigh that. That does not mean that that's our goal weight for them. It's just a number, because we don't like to talk about pounds and obsess over weight at every visit with these kids that are already obsessing over weight. So we try and use sort of this percentage to talk to them about this stuff. So when do we admit them? If they are less than 75% of mean estimated body weight, then they need to be admitted. A lot of times it's hard to convince insurance companies that they need to be admitted at that, but that's what the data from the Society of Adolescent Health and Medicine recommends. Dehydration, obviously, electrolyte abnormalities. So if their potassium is low, they're at risk of heart failure, right? They're at risk of cardiac arrhythmias, which is the next item on the list, cardiac arrhythmias. QT prolongation is also one. growth arrest. So some of these kids, they come to us and like I said, they haven't really entered puberty, their growth stopped, the curve flattened out, and they're not able to do it at home, everybody's really struggling, bring them in. Physiologic instability, so if their heart rate's less than 50 while they're awake and talking to you, if their blood pressure is less than 90/45, and if their temp is less than 96, they need to come in. Failure of outpatient treatment, right? If I've had 3 visits in a row and the kid has lost weight 3 times in a row, they're coming in. If they are refusing food, just refusing food in general, refusing food and drink, refusing supplement replacement, they're eating less than 500 calories per day. And acute food refusal technically means no food for 2 days, 48 hours, then they need to come in. Uncontrollable binging and purging, they can't stop themselves, medical complications, psychiatric emergency like suicidal ideation, especially active suicidal ideation, comorbid diagnosis that's interfering with their treatment, and then sometimes the families just need a break. So I had a kid, and she came in, she was a new patient, she had had atypical anorexia nervosa, and her heart rate had been abnormal before, but now was fine, and family was just done. They had taken away her phone. They had put her on rest in her room. They had taken away everything. She was okay with it. She wasn't eating. She just would not eat. There was nothing they could do to get her to eat. I was like, all right, just come on in. Well, we'll get her eating for sure. But sometimes they need a break, and they're just at their wit's end, and they don't know what to do anymore. And that's okay. So what do we do when we stabilize them? The first thing you do is prevent refeeding syndrome. Don't worry, that's like the next slide. Monitor their calorie intake in a controlled environment, right? So you don't want them to go from 0 to 1,000, because that's what gets them into refeeding syndrome, okay? Encourage structured meals with a time restriction and replacement if necessary. These kids will drag out these meals for like an hour and a half, and we can't do that, because then you're into the next meal and you're not hungry for that meal, so we need discrete time. And then replacement for those that don't eat. So what we usually offer is we say, okay, you can eat your meal. If you don't eat your meal, you get boost replacement of approximately the number of calories you still have left. And if you don't drink the boost replacement, then we do put it in a cheat tube and put it down, because they're there for malnutrition, right? And people are like, oh my gosh, you use a tube? Like, first of all, it's in and out. It's really fast. Second of all, I can't let them not eat if they're there for malnutrition, right? They can't lose weight while we're treating their malnutrition in the hospital. It's not okay. It's medical neglect at that point. And then stabilize their vital signs and treat signs and symptoms with supplements, and that and vitamins, mineral supplements, that sort of thing, bowel regimen, and electrolyte replacement as needed. We start them out in our hospital. When we get a kid in that's malnourished, we actually start them off on potassium phosphate to prevent refeeding syndrome. We've only ever had 2 kids go into refeeding syndrome in the last 3 or 4 years, and they both cheat their meds. So it really does help, and it helps stave that off a little bit longer, and it makes it so that we don't have to check their labs every 6 hours. Instead, we can do it every other day. We can space it out. Now, if they enter refeeding syndrome around day 2, 3, 4, then we need to check more often. So what is the definition of refeeding syndrome? So it's the clinical complications that occur as a result of fluid electrolyte shifts during your nutritional rehabilitation in malnourished patients. What they figured out, so most patients do well no matter how little they've been eating, in theory, starting at about 1,500 calories per day. They kind of did a study comparing starting at 1,000 calories versus starting at 1,500 calories. They're still going to need to probably get to the same place. So if you start at 1,000 calories, it's just going to take 2 more days, right? Because you go up about 250 calories per day, up to 250 calories per day. So it's literally just going to take 2 more days to get to that end point. And it didn't actually prevent refeeding syndrome any more than starting at 1,500 calories. So starting at 1,500 calories-ish, we start more like 1,750, a little bit more, is the way to go. And then increase slowly. So no more than 250 calories per day. What, again, from the Minnesota starvation study, as well, actually, more importantly, from the 1940s, when they liberated the concentration camps, they saw all these people that had been starving. And what do you want to do? You want to feed them. And what happened? They died on the 2nd, 3rd, 4th day. They died because their heart stopped. Because all of a sudden, you had, what happens when you eat? What hormones release when you eat? What does insulin do? shuttles everything into the cells, right? So it's shuttling potassium, phosphate, magnesium, sugar into the cells. All of a sudden, your muscles are no longer bathed because you're overall depleted, and your muscles are no longer bathed in that potassium, phosphate, magnesium. Phosphate is the issue because then you run out of ATP and your muscles, including your heart, can't contract. So sudden cardiac death, big issue. So being cautious is important. Okay, so what happens? All right, so you got starvation and malnutrition, right? You're in glycogenolysis, gluconeogenesis, and protein catabolism state, okay? So everything gets depleted. Salt and water intolerance because, well, you don't have insulin working. And then all of a sudden you switch to anabolism. Fluid, salt, nutrients come rushing in. Carbohydrates are often the major energy source, which means more insulin secretion, right? And then that leads to protein and glycogen synthesis, which means increased glucose uptake, increased utilization of thiamine, so you can get up Wernicke's and Korsakoff's, and then uptake of the potassium, magnesium, and phosphate. So that leads to hypokalemia, hypomagnesemia, hypophosphatemia, thiamine deficiency, salt and water retention, severe edema, yes, this is a British slide, which is refeeding syndrome. Okay, so what's the risk factors? So if they're less than 70% of the estimated body weight, they're at greater risk for refeeding syndrome. If they've had abrupt weight loss or huge limitation of their calories for a long time, so one of my patients was eating 100 calories a day, and so she went into refeeding syndrome, and she cheeked her KFOS. If you give them a sudden carb load, and then if they've had starvation for 5 to 10 days prior to refeeding, so they've eaten nothing, and if they're starting out with low levels of MAG, K, and FOS, prior to refeeding, obviously they're already depleted, and you're going to deplete them even more. The highest risk is during the first 10 days. Day 4 is usually the peak of nutritional replenishment. So paying attention during those first 2 weeks is really important. So how do they present? So prolonged QT, U waves, T waves, reverse T waves and U waves, edema, often pitting. Sort of the signs were like the what is it, Schwarzschild sign or something, and then the other one is the blood pressure cuff one. Yep, where all of a sudden their hand is in tetany, basically, from the electrolyte imbalances. Vitamin and mineral deficiencies. So this is an example. You can see that this kid has kind of this rash right around here. It's related to mineral deficiencies. I think that's supposed to be abdominal pain. Sorry. Loss of hair. Kind of cheilitis at the edge of the mouth. So the zinc deficiency is the acrodermatitis enteropathica. B12 deficiency is this angular cheilitis. Hair loss is from biotin deficiency. And then confusion and this is apparently confusion and yeah, I didn't make this slide, sorry. Thiamine deficiency, confusion, Wernicke's encephalopathy can occur. And for thiamine deficiency, you need to supplement for about 6 weeks. And this doesn't just apply to anorexics, right? The PICU attending that I met at a dinner the other night texted me to ask me what to do about thiamine deficiency because they had a kid that came in refeeding syndrome because they had medical neglect at home, basically, or just period neglect. And then my colleague, who's a NICU attending, had a baby who was being starved. The placenta was starved, and so newborn preemie in refeeding syndrome. So it happens to all ages. So how do we treat it? Feed slowly, increase slowly. Space the meals out, 3 meals and 1 to 3 snacks per day. Supplement with zinc, multivitamin, and vitamin D replacement or treatment. And then fix those electrolyte imbalances. So KFOS is a pill, Fosnac is a powder. A lot of them are on magnesium oxide, also helps with the pooping, so that helps. If they're tolerating PO and they're not super depleted, we try and feed. Otherwise, if it's really bad or if it's phosphorus and really low, we do IV. And then you want to monitor daily if this is started, and maybe increase it if you need to, at least twice a day sometimes. And then you want to monitor for arrhythmias and repeat that EKG once the electrolytes are normalized. And also once they're closer to sort of their mean estimated body weight, their QT prolongation, et cetera, will normalize. The other issue is that we're often giving these kids antidepressants, or their other psych meds, or Zofran, which all also prolong QT. So being careful of what meds you're giving them. We had a kid, he was on Zyprexa and Prozac. Well, yeah, his QT was abnormal, and then so we stopped the Prozac because the Zyprexa was helping more, and so luckily it normalized. Oh gosh, this is tiny, I'm so sorry. Okay, complications of eating disorders. We've talked about a little of these. Decreased cardiac mass, reduced chamber volumes, the mitral valve prolapse, myocardial fibrosis. There is some evidence that that is permanent. Okay, so they get basically mild, minor scarring at the cellular level in their heart, and some of that is permanent and will not go away. Pericardial effusions. Ipecac, if they are using Ipecac to vomit, it induces myopathy, which can also be permanent. Gynecologic, we talked about amenorrhea, which obviously affects fertility, and though that's not to say that just because they're not having their periods doesn't mean they can't get pregnant, which would be horrible. Endocrine, hypothalamic pituitary abnormalities, severe bone loss. So we get a DEXA scan on these kids, and the bone loss can be pretty bad. Usually, feeding is the most important thing to improve it, but sometimes we have to use estrogen patches. Birth control doesn't help, but they need estrogen. Dental, discoloration, caries, and gum disease. Gastrointestinal gastroparesis and constipation, so that's the nausea vomiting, right? GERD, Barrett's esophagitis. For those that have been vomiting for a long time, put them on a PPI, because even though they might still be vomiting, you can decrease the acid load and help them not get cancer of the esophagus down the road. Dysphagia. Superior mesenteric artery syndrome, really uncommon. I've seen it like twice. If their pain seems out of proportion to what is happening and it doesn't make sense, check for superior mesenteric artery syndrome with advanced studies. Because what happens is that fat pad that keeps the superior mesenteric artery from collapsing, basically that fat pad is gone and it's not propping up, and so it kind of pushes down, and then their blood supply to their gut is cut off. So they literally can't absorb, and it's extremely painful. And in that case, you either need to do an NJ, because you're bypassing that part of the intestine, or TPN, which has its own complications, right? Pancreatitis, hepatitis, diarrhea, because they can have villus atrophy, and Mallory-Weiss syndrome for those that are vomiting. Renal, reduced GFR, difficulty concentrating their urine. Sometimes it takes a few days and we have to water restrict them, because some of these kids have been drinking 4 liters of water per day. And so we have to restrict their fluid intake. They can end up with diuresis, hypernatremia, and dehydration. So we check their UAs every morning, when in theory it should be the most concentrated, right, because they've been sleeping all night. We already talked about electrolyte imbalances, and then nephropathy can occur as well. Oh, it did work! Yes! Okay, so this is the picture of the decreased heart volume. So you can see normal heart, BMI of 19, BMI of 12, right? So can you see kind of the proportion of decreased cardiac mass that's going on? Yeah, okay. And you can see this is the CT scan, or the, CT scan version of those same hearts. Okay, so what else? Weakness and wasting of respiratory muscles. Listen to their lungs. If you start hearing crackles, realize that they're probably in congestive heart failure, and that they also are having problems breathing. So they'll get dyspnea really easily. Reduced aerobic capacity, decreased pulmonary capacity. This was actually one of the questions on one of my boards. I don't know. Hematologic, we already touched on a little bit. 83% of severely ill, which is BMI less than 15, I think. Severely ill patients will have anemia, 79% will have leukopenia, and 25% will have thrombocytopenia. They can get Wernicke's encephalopathy, they can get Korsakoff syndrome and brain atrophy. They can get lagophthalmos in severe cases, where basically they literally can't close their eyelids all the way because there's just not enough tissue there. And so then they get dry eyes, they get corneal abrasions, they can get all sorts of problems. And now I can't see. There we go. Dry skin like nobody's business, like dry, cracked hands. Lanugo from the increased cortisol. The hair loss is from telogen effluvium as well as B12 deficiency. Sometimes they turn yellow. So they'll be like a yellowish color, which is keratinoderma. Slow wound healing, bruises, that sort of thing. So what does the research say? There's limited evidence-based research on approaches to treatment. Because a lot of this is therapy, right? It's kind of hard to do research studies on therapy. I mean, it's possible, but it's hard, right? For teens, family-based treatment works best. So having the family involved, having the family take over some of the responsibility, so the kid isn't the one feeding themselves, that sort of thing. The earlier they get treated, the better their outcomes. And actually, younger kids actually do better unless it's not caught till much later. And those with psychiatric comorbidities tend to have worse outcomes, which I think probably makes sense to everybody. So what questions do you guys have? Oh, it's 11:30. What questions do you guys have? Yeah.
So for the most part, other than the stuff that you like specifically mentioned, that kind of can be like a lasting problem, once they start to recover and the malnutrition improves, do most of those things just go away?
Bone and brain, there's some evidence that there's going to be, and cardiac, some evidence that there's going to be permanent effects. And fertility is usually the last thing to come back. It usually takes 6 months at restored weight. But yeah, most of the things do get better. We can fix a lot of this. And like the bone and brain, it's like the bone will get better, but it might not catch up to where somebody else would be. Yeah.
Once you get to the level of using SSRIs in some of the patients that can tolerate that, what is the long-term course of the disorder? Are they going to be under treatment for the rest of their life, or do they ever reach a place where maybe they
that's a good
get
question.
an appreciation for what happened to them?
So most of them do recover. It's like 45% do recover completely, especially for the adolescents. The SSRIs, I mean, we tend to use those a lot because a lot of the kids also have a little anxiety and depression, right? So we tend to use those a lot. I don't know that there's been a study that shows if their course is different. We usually keep kids, especially kids with an eating disorder, on SSRIs for about 2 years at a decent dose. But most of them can come off it. Most of them can come off it, and most of them do well. So,
And a follow-up question. What psychiatric disorders are they more prone to if they have this in adolescence and they're treated to the place where they can be functional on their own? Are they prone to other things as adults?
I mean, they're always
I almost think they probably are.
Yeah, they're always at risk for relapse. I think anxiety and depression is still pretty high. I don't think it necessarily is going to affect, well, bipolar less, schizophrenia less, but anxiety and depression do tend to, those ones might be around a long time, and the relapse is a big issue too. Yeah. Usually as a young adult, 20s. Do you guys want to do a case, or do you want the rest of the day off? You do? Raise your hand if you do. It's okay, I won't judge. I don't know who any of you are. All right, we'll do a case. Okay. It's like I don't know who anybody's name, so no big deal. All right, this is my lovely email address. It's my name, Shauna-Wallace, because OU's weird, at ouhsc.edu. And my name is spelled weird. It's S-H-A-U-N-A, and my last name is L-A-W-L-I-S, like illiterate horse thieves, as my grandmother used to say of her in-laws. And then OUHSC. Yep, and that's probably where it comes from, actually. Lots of fun references, up to date's your friend. And good resources. Okay, so AT is a 16-year-old female who presents to clinic with complaints of fatigue, abdominal pain, and weight loss. She comes in with her grandmother, who states that she's concerned about her eating habits. So what do you want to know? Yeah, 24-hour recall. Yeah. What else?
How much does she weigh?
Highest and lowest weights, how fast the weight loss. Yep. All right, so the time frame, the behaviors that grandma's worried about, the eating behaviors, her body image, how she feels. She had periods. You want to know her vital signs, right? What's her weight, what's her height, what's her BMI, what's her mean estimated body weight, what percent of mean estimated body weight is she at, what's her heart rate, and what are her orthostatics doing. And then, of course, you have a physical exam, right? So you want to look for edema, bruising, skin findings, or pharynx, all the stuff we already talked about. All right, so she reports that she had a health class about 6 months ago, that asked them to monitor their meals for 3 days and taught them about BMI. I have actually had coaches and nutritionists tell kids that it's okay to not have their periods, tell kids that it's okay to be underweight. Tell kids that it's okay to be bradycardic. I've had people tell them that, and I'm just like, oh, my favorite was one of my patients recently went to figure skating camp, and one of the other kids' coaches told her, this is a girl in recovery from anorexia, told her if your hips were skinnier, your jumps would be better. Yeah. I really wish I could find that coach and kill him. I was so pissed, and she'd been doing so well for so long, and now her heart rate's in the 40s again, and I was just like, okay. So she has been really focused on how much she takes in and has considered becoming a vegetarian. There's nothing wrong with being a vegetarian, it just depends on how you do it, guys, okay? Like, I'm not trying to hit on the vegetarians, low carbers do it too, it's all sorts of people, okay? So she's, grandma's really knows that she disappears after eating. And she hears strange noises coming from the bathroom. She even found some pieces of food in the toilet after dinner last night. The last period was 6 months ago. Yeah. Starting to get worried? Okay. So her physical exam. Okay, so her vital signs. Her weight is 110 pounds, not too bad. How tall is she? 5'10".
Oh my God.
She's very tall for her age. Her BMI is 16.3, okay, that's low. What is her weight supposed to be? 62.6, so she's at 79.9%. That's actually not even that bad. How sad is that? That's only mild malnutrition. But it's striking when you see them. Her blood pressure, okay, so it's 100/60, not bad. Her heart rate is 47. Her temp is 35.6. When she stands up, her heart rate goes up 28, and her blood pressure drops a little bit. Not too bad. 5/2. Okay? So, is any of this concerning to anybody? Yes? Yeah, her temperature is low. She is hypothermic, she's bradycardic. She's got POTS, which is postural orthostatic tachycardic syndrome, which is sometimes from malnutrition. Other things cause it too, but in this kid, it's probably malnutrition. What does she look like on physical exam? Okay, so she reports dizziness with standing, and she's pale, but comfortable. She's got fullness on her parotid area. She's got some dental erosion. Her hands are kind of yellow, like thickened skin on the palms, and she's got excoriations on her wrists and thighs from her dry skin that she's been itching a lot of. And when you listen to her heart rate, it's about 47. Her lungs sound good. She's a little bit tender to palpation in her lower quadrants. That's from the constipation. She's got, her back looks okay though. So you always want to check their back, and you want to check all the way down, especially on the kids that are really underweight, like less than 75%, because a lot of times they will have ulcers. They'll have sacral ulcers, decubitus ulcers, it might be grade 1, et cetera, et cetera. And I really mean check, like get them on their side and roll them over, because sometimes it's so low you can't see it. I missed it the other day, my colleague caught it. She's got calluses on her index fingers bilaterally from purging. So what's next? What do you guys want to do?
Send her to you.
Yes. You can always phone a friend. Yes, you can totally send her to me. What labs? Do you want to get some labs beforehand? Yeah? Okay.
Did you get an X-ray of her chest?
I think she's probably okay right now. If she starts having crackles, I would, to see if she's got like edema. Yeah, TSH, yes. Yep, she hasn't had her period. Might want to look at that. Pregnancy test too. What's the #1 cause of amenorrhea in young teenage girls? Correct. Yes, and there was actually a girl at OU at one point that got sent to everybody and finally got to endocrine before they finally did a pregnancy test. Wow. Yeah. First test, really easy. You can run it in your office, I promise. UA, yeah, totally. Okay, so wow, that was slow. Okay. Yeah, so ESR, anemia, check for anemia, inflammatory bowel disease, and inflammatory concerns are what you're looking for those. The CNP, the electrolyte imbalances, the liver function, the kidney function, UA, the spectrum. Have they water loaded? Have they not? Do they have an infection? Is that what's causing problems? It would have been a really impressive infection if it had gone on for 6 months and it would cause like weight loss. EKG, especially with the bradycardia, and then a TSH, or they have thyroid issues, because thyroid problems can cause weight loss and bradycardia as well, right? So it's important to check that too and rule out sort of the organic cause, the non-malnutrition causes. All right, so here are her lab results. So her CBC is fine. Her CMP, her K is 3. What's normal? Right. Her UA, her spectrum is 1.002. So this is actually not detectable on ours in our clinic. 1.002 is water. So that's basically she's had so much water, or her kidneys are not working well enough, or a combo. And it usually takes a few days to really regain that salt gradient in your kidneys. A few days to a few weeks. Her QTC is 460. Another concerning finding, especially with that bradycardia and the potassium, right? Because potassium can cause arrhythmias too. TSH is fine. Okay, so does she meet admission criteria?
Yes.
Yes. What criteria does she meet? Yeah. Electrolytes, right? EKG. All right, so she's got the heart rate problem, she's got hypokalemia, she's got temperature, she has orthostatic changes, and she's got a prolonged QTC. All really good reasons to hospitalize somebody. This is the review of the criteria for admission. We saw this slide already. But yeah, and then the other reasons like the syncope, hematemesis, esophageal tears, intractable vomiting, and suicidal thoughts. Oh, that's the end of that. Sorry. Okay, so that's the case. So that's when to hospitalize, basically. Yeah, does that make sense? Okay. And we usually keep them for a long time because there's not many resources in the state. Like I don't have a place that I can send them for a partial hospitalization program, and we don't have the resources because there's 3 docs, 2 therapists, and a dietitian, and like 2 nurses, 3 nurses. So on a good day, 3 nurses, and 1 person at the front desk. So we don't really have the staff to like bring a kid in all day long and do therapy all day long because our therapists are doing therapy on the floor in the morning and therapy in clinic in the afternoon, and we're doing the same. So, you know, we just kind of keep them until they're ready to go home. And what we do is we keep them, we get them up to about 83% of mean estimated body weight, and then we start doing unobserved meals. And so that's kind of to give them a practice of how they're going to be on their own. We encourage the family to come in for some of the unobserved meals and for them to eat by themselves and other unobserved meals to kind of mimic what real life is like. Because, you know, you're having lunch at school with your friends, but then hopefully you're having family dinners and that sort of thing. And we do encourage the structure around the meals. And then once they get used to having 1 or 2 unobserved meals, they can bring in food from home. They have to bring in enough, so 1 sushi roll is not going to be enough. And then they move up to 3 unobserved meals at 85%. Once they complete a day or 2 of that, they're good to go. But that doesn't mean they don't get readmitted. We have some kids that have been admitted a few times. I totally just lost what I was going to say completely. I hate it when that happens, and I'm not going to remember it, but that's okay. Oh, no, now I remember. A lot of these kids, especially the ones that are more underweight, leave eating 3,000 to 4,000 calories per day. Their metabolism is getting ramped back up, and they were underweight, so we're playing catch up, right? So like 2,000 calories a day is maintenance for most adults, but these kids have to catch up. So even at 85% of mean estimated body weight, we have them eating a lot of food, a lot of food. And here's the problem, because a lot of them are still a little fat phobic, right? So they're like trying to eat it all in bananas and grapes and strawberries and broccoli. I had one girl and she would literally eat a turkey wrap at every meal with broccoli, at every meal. And it was like, eat some cheese. It's like you need to have those calorie-dense foods because the volume gets too much. And they'll tell me this is too much to eat. And I'm like, yeah, you're right. Eat the peanut butter. It's 5 points. Like it's like 300 calories for the peanut butter. Don't eat the 3 bananas. That's gonna. Of course, that's too much. So they'll still be trying to focus on that, but we really need to work towards getting them to eat calorie-dense foods. Add the bacon, add the cheese, add the mayonnaise, add the avocado, add the peanut butter. Drink the milkshakes. That's another thing we do offer milkshakes. Once they get up to a certain number of points, we're like, have all the milkshakes you want. Not really, I mean, we limit it, but trying to encourage them to find alternative ways. I had one kid and I sent her home and she would have to drink a Boost, and then she's like, I just got tired of the Boost, so I started eating cake and ice cream. I was like, great. So she was like, I've just been binging on sweets every night. Not really binging, but she's been eating the appropriate amount, but she was like, every night I just have cake and ice cream. Okay, you go for it, girl. And she gained her weight back, and then she started becoming a speaker to talk about her experience when she hit the next year. So, yeah, she was far enough removed from it that she can talk about it. Yeah.
So people who are able to recognize things by themselves and they try to seek help by themselves, is it recommended that they do you and like they go for it, or is it more recommended that they come in and see y'all to get the proper?
So I would still recommend that they use some sort of a multidisciplinary team. some sort of dietitian, therapist, and a medical provider. If their PCP is comfortable in handling it and they are motivated enough to get better, great. I think it's easier if they have people that are experienced with it, because it's really hard to convince people to eat when they don't want to. Like, ask a parent of an eating disorder kid, it's totally counterintuitive. And sadly, I went for 3 extra years of education for this, but that doesn't mean that other people can't do it. I think it helps to have a team. But if they're motivated, that's great. If they're, most of them are the young kids or the teenagers, and their parents are dragging them there because they're freaking out because their kids lost, 60 pounds, and they look horrible, and they're not able to stay awake, and their sleep's crap, and they're having all sorts of problems. So, but yeah, if they find a team that works for them, great. Yeah. And there's Living Hope, which is in Norman, and then there's Laureate is up in Tulsa. Yeah. So those are the other programs. Any other questions?
Just as a very practical question,
Yeah.
I know that center care is an issue in terms of payment for things, for almost anything. Do you feel like private insurance has caught up with eating disorders so that if you have private insurance, let's say Blue Cross Blue Shield, you could get the services you needed?
Yeah, I think the private insurance is okay. It works pretty well. There's like one of my patients that has one program that's through the state, because technically I think they're state employees, they work at the Capitol. And that one I would not recommend. It's like the global health one, because I literally have I have to send in prior authorizations, which I'm happy to do, but it's more of an issue that they're trying to say that none of it's covered, basically, that I'm not in network.
So you're just fighting every step
Yeah,
of the way
it's
for
horrible.
the care.
And I basically told the family, I was like, you need to switch healthcare for her next year, because she's chronic and she's really struggling. We hospitalized her, she's at 85%, and now we're just hovering 85, 86, 87, it's been 6 months. This kid is like up and down, up and down, up and down. She's gained 2 pounds since discharge 6 months ago. And basically I said, okay, you're either coming back into the hospital, which I kind of don't want her to, because she had a really good time the first time. She made a lot of friends and was queen of the floor, and I don't want the secondary gain aspect of things, and also it's a lot of complications, but family issues, etc. So what I'm doing is I'm bringing her in every day. I'm weighing her, and if she hasn't gained weight, she gets to drink some Boost, which is annoying for her parents, but it's probably better than hospitalization. So, yeah. So she gets to drink Boost every day. So, yeah. Anything else?
Thank you so much for coming.
Yes, thank you. That was helpful. 15 minutes to spare.